economist, and I was explaining if so 20 out of 30 times a day, a person, instead of just picking up a phone and calling me, they have to go through a gauntlet of the reception, scheduler, in window, out window, doctor, nurse, and insurance system for something that I could fix in 5 or 10 minutes on a phone call. So I blame my wife. She sat down and said, you're going to have to change healthcare. And she sat down with me and we developed a business plan that had several components. The first component was develop it doesn't mean that you don't ever need to be seen, by the way. It just means that if you know me and I know you, half the time at least when you're calling, you either know what it is or I know what it is. And the next step is getting you a medicine or sending you to the lab, or maybe you need an x-ray, or maybe your story says you need to go see a specialist. You should bypass me. This is an issue where you need to go to the see a specialist. So the aspects of the practice that got developed were, how do you build a communication-centered practice so that people, when they're having a problem, I become the first one to know, not the last one to know that something's wrong. People can call me on my cell phone, they can call our business line, they can text me, they can email me. So there's many ways of streaming information to me. And that way I can be on it right away and try to figure out, do you need to be seen? Should I call in a prescription? Should you go to the emergency room? And this helps me then help manage your care in a much more sophisticated way. On top of that, I would say many times as you walk through the desert to get to the doctor in our current healthcare model, where you've had to wait 3 days and go through 16 people before you got to the doctor, he gives you a treatment, he or she, and the next day you're not any better, or maybe you're having a side effect to the treatment they gave you, and you have to make a decision if you want to walk through that gauntlet again to get health care. Whereas in our system, if something's not right, you just pick up the phone and call me and say, I'm developing a such and such a symptom with this medicine you just gave me. Is that a side effect? And I can right away help figure out what's wrong. Do we need to change the medicine? Is this related to your medicine or is it not? So that we can micromanage the problem as it goes along if you need any help. So that was the first aspect of the care, was to develop a communication-centered model. So we do see everybody when they need to be seen. We insist that we don't take care of strangers, although in this era of COVID, we're accepting anybody who needs to be seen. We don't make them force into an office visit because of the situation. So we want to make sure people get the care they need. The second thing we developed was a transparent pricing model, because the current insurance model is based on so many layers of not understanding and non-transparency. It literally drives me angry every time I see it. Every time I have to touch the healthcare system myself personally, I'm enraged by the way the billing is.
And I think, I don't want to interrupt you, but I remember when you explain this to our pro-aging audiences, is that one of the frustrations that you had when you were in a traditional practice was, I think it's a statistic that there's 4 office workers for every 1 physician in a practice. Right. I know that's become a little more streamlined since you have done that, but that really rang true. And I think when we go into traditional medical practices, you can see it with all the staff that are there in the office.
Yeah, it's very true. And all those layers then add cost to the whole system. As long as you have insurance and you don't see the bill, you don't care. But as soon as you have to see what really is happening to the price, it drives you crazy. So the transparency in our model is you pay me for time, which is how the rest of the service economy mostly works. If an accountant charges you on time, lawyers charge you on time. That way you can police the time, and if you think I'm overcharging you, you can fire me. So we're trying to make sure that people understand that we're trying to be as honest as we can. We try to create solutions also inside of that, of trying to help people understand how things are priced, laboratory tests and x-rays, and if you need them and you don't have insurance or you have high deductible healthcare plans, how to get you an affordable price. Because we're all about making sure that the price is understandable as much as we can, because well, even I don't understand all of it because it's so complicated, and then trying to figure out where are the places where we can get you good prices. These drugs aren't that expensive. Let's get you, and so we can help people manage the pricing on a lot of these other parts of healthcare. So that was the second part, trusting relationships. We built our own medical record system so that it serves what I need it to do, which is to deliver me high quality information. So not only does it have your records, but when you say what's the side effect of that drug, as soon as you say that question, I can see the side effects of that. I can pull them up right in front of me. So it helps me help manage differential diagnoses or what kinds of tests are in the workup that I haven't thought of. Treatment options, so if you're allergic to X drug, I can pull up within a half a second other treatments that are scientifically validated. So if you're allergic to penicillin, what's the next best choice if I'm not sure? So it helps me manage information. The idea is, how is it that I can get with a computer and the source of information it can provide is really, does the answer to this question, it should be within seconds from my fingertips. This resource of my brain is a limited resource, unfortunately, and it can't manage all that information, but a computer is phenomenal at being able to show you the side effects of the drug in half a second, or know a differential diagnosis that you have, things that you haven't thought of in half a second, so that it can provide me better information to manage your care better. So those are the major components around how do you build a practice. I love, Steve, that you kind of tried to point out that I'm not a VIP. It still rankles me that people want to consider me a VIP doctor or an exclusive doctor, and I've been accused of that in medical meetings. I was often, one of my favorite comments was a guy saying that I cherry picked off the rich people. And I will say that it is true that I do take care of people who are CEOs and lawyers and high-end executives. Their time is so valuable, they don't have time to waste to go to the healthcare system. They have the best health insurance in the world, but it costs too much of their time to go get it. So they don't mind paying me 60 or 80 bucks to figure out what it is that they need and get it to them right away. But the other group that is my major constituency are people who have high deductible healthcare plans and no insurance, because I'm all about trying to make sure they get a good service at an excellent price. Yes, it costs money. I have to stay in business, but I am not a get-rich kind of person. I am about how do you deliver and transform our healthcare system, because right now what we have is just ridiculous about how people get their healthcare through
Yeah,
the gauntlets.
and I will attest that I again, going back to the pro aging, when you first explained your practice many years ago, the concept that somebody without insurance can have a doctor like you and pay for it on their credit card is amazing, and it's a model that we should be thinking about. I will say that with some of the medical procedures that I've used when I've used your office, because our conversation was so short and quick, I let's say I left a voicemail about what I was concerned about, and because you were able to prepare and do the search when you call me back, and the bill was so low, even though I can submit it to my insurance company, I just pay for it. And you know, healthcare is something that is worth paying for. I mean, it really is. I mean, you know, we have no problems putting a big widescreen TV on our credit card, but the value that you get out of, you know, the advice that a doctor is giving you can be way more valuable than that. One of the components that I want to make sure that the audience knows about is the fact that when you started this practice, you were doing house calls too. Like, you built it so that you could deliver medicine anywhere.
You're absolutely right that one of the services that is not easy to get, and especially for the aging community, is house calls. And again, almost all these things that I have had to try to work on are things that are really have not been possible to do under an insurance model. The reason a doctor would never answer a phone call and get you what you needed 50% of the time is because it would put them out of business, because under the insurance model, it's free care. And so getting healthcare in the standard model up until COVID, when suddenly everybody started to talk about telemedicine. But getting healthcare prior to that was a doctor on a telephone was free care, and he had a whole staff and office and a whole high overhead to support. So his job was to never get on the phone and just mass produce people in the office, and to generate lots of bills to the insurance system. So in order to build this practice, I had to walk away from the insurance model, who dictated to me what they were going to pay for, and also often played lots of games around the billing system that would drive me crazy. So that was one thing. The second part around the house calls, Steve, is that what happens with house calls is there isn't a way to, Medicare won't pay a doctor enough money to get your house and back. And by the time they send the bill in and wait, they get $120 for something that takes the doctor 3 hours, which means by the time he pays his overhead, he's out of business within a week. So you can't. So I had to walk away from the insurance model, not necessarily because I wanted to, but partly because I didn't know how to transform healthcare, waiting for the what I call the church of health to transform itself. I decided I needed to go build something from the bottom up, since they weren't interested in this idea at all and wanted to keep everything as it was. So
Awesome. Well, that's a great overview. And again, one of the things we're going to do over the next weeks and months is spotlight providers like Dr. Dappen. So I know, there's other providers out there that are getting innovative, and we want to spotlight them. But this is not, even though Dr. Dappen is my personal physician, this is not an endorsement. This is not a commercial. This is just meant to be a resource for all of us who are out there serving older adults. Okay. So let's get into some of the things that you're seeing. So first off, I think the most important thing is you haven't really modified. I mean, I know that you've got, you're meeting people in the parking lot and you're doing some things like that, but in general, how many years have you been in practice? And with COVID-19, what are the changes that you've made?
Well, so I graduated from medical school in 1979. So that gives you an idea of how long I've been out there. Um, and we've been practicing at DocTalker in this particular business model for 18 years now. So I haven't really had to modify with the change of what's happened in the last 2 or 3 weeks. We haven't really changed really anything. All of our patients continue to call us whenever they need help. We are not doing a lot of the standard things that could wait, like wellness visits or anything that doesn't seem urgent. We just keep telling everybody, let's not take that risk. And I can't do a wellness visit just on the telephone. So you'll have to have an office visit for that. So I will see people in the office if they need to be seen, if they've had a cut or ear pain. If they're having something that's fairly urgent, I will take care of them in the office, but I don't let anybody who's got symptoms that seems like it might be COVID to walk in the office. I'll meet them out in the parking lot. And I have a specialized little rain suit that I put on and look pretty funny as I walk out into the parking lot to take care of them. We've done a handful of swabs. I think we've done 7 so far for COVID. One of them was positive, so we've had 1 positive patient. But fortunately, he was young and did well.
Okay.
So, but otherwise, yeah, there isn't. I've still been doing a few house calls. Of course, I have to gown up a little bit and put on a face mask and gloves when I walk in to try to make sure that if by any chance I was contagious, I'm trying to reduce my chances of getting it and or transmitting it.
Well, yeah, I mean, that's one of the things that all of us on this call, our heart goes out to frontline medical staff like you, because we know every time you're going to a patient's house or meeting with the patient or somebody comes into your office, you're at additional risk. I have some questions to ask you, but I wanted to address a question that Ralph posed. And just for the attendees, you can ask questions or make comments one of 2 ways. You can use the Q&A button on the bottom, or you can raise your hand and we'll work on getting you on the call as well. But Ralph asks, I just learned that Medicare will pay for telemedicine during COVID-19? Can their payments suffice in your pricing? I think I know the answer to that, but I'm curious at how you would answer that question.
Well, they do have a set of codes now that they have just issued for telemedicine services. I don't know what they're paying on those calls. One of the things I had to do, unfortunately, in order to provide the care I do, is I had to opt out of Medicare so that I could do house calls. Opting out means that I'm not allowed to bill Medicare, and people who get the service, my bill is separate from. I can bring in Medicare services, I can bring in nursing, I can call in medications or get home X-ray to come and see you. All those services are covered under Medicare, but my particular part of the bill is not billable except as a secondary insurance.
Right. And so you have Medicare patients, but they're not billing your services through Medicare.
Unfortunately, it's not billable, correct?
Right.
So
Now,
I don't know, and I haven't seen anything from Medicare saying that just because once you've opted out, you can only opt back in every 2 years. So they basically they just treat you like a leper, and basically you're pushed out of the system, and every 2 years you're allowed to go back in. So I'm not and it's during a 1 month window you're allowed to opt back in. So I'm out of the Medicare model there.
Okay, great. Well, we've got some more questions, and I've got somebody's raising their hand. But before we get into that, give us your thoughts on the COVID-19. Like, what are some of the things that you're seeing? I know different things cross your desk than cross our desks. We get press releases, we hear CNN, but are there any sort of insights that you could share with us as providers and consumers to help us digest what's going on?
Thanks for that. I actually do have, last week, I try to put out a newsletter to all of our patients. I've been doing it a little more frequently because of the COVID thing. But the one I just put out last Saturday, I thought really helped me transform my idea of how to prevent getting this disease. This disease is not, it's scary if you get it, especially if you're in that subtype that ends up in the hospital. But the disease itself, to prevent getting it, is not that hard. And I think it's likely to be very manageable based on what we think we understand now. And so in this email I sent out, I invited everyone to watch an hour video, but and I'll be glad to send this email to anybody if they want to see it. But this video is a pulmonologist who's working up in New York who explains the transmissions of how it happens. But then I have a little summary underneath it. And here's the summary, which is that almost all transmission of COVID is hand to face. It's basically people who are sick and they are transmitting this disease many times without knowing it. You're shedding this virus asymptomatically when you're breathing out or speaking. Speaking puts these droplets into the air. So this stuff goes out and it's like glitter. That was the metaphor I used in this, that I adopted from this talk, which is glitter comes out of your mouth, and when you breathe, it goes out and then it drops. And it lands all over the surfaces. So contagious people are spreading glitter everywhere. And then you touch the glitter, and then just because we are always doing this, we seem to be creatures where we have to touch our face. We go this way on the hand, glitter, and into your face. That's how you get 90% of the time. That's how you're getting this infection. So this is why you cannot touch your face unless you know your hands are clean, like you've just washed them or sanitized them. You should assume that your hands have glitter and you should never touch your face. That's the first lesson. And anytime you touch the surface that you're not sure, wash your hands or put disinfectant on them. That's lesson number one. Lesson number two is, because this is glitter and we're shedding it asymptomatically, everyone should be wearing a face mask, period. It doesn't have to be a fancy face mask. It just needs to be cotton, maybe a couple layers of cotton. It can be a bandana, because as we speak and breathe, this stuff is coming out and it's going out into the atmosphere and down onto the ground. It doesn't sit in the air floating very long. It goes down, and then you're contaminating everywhere and everything. If everyone had a face mask on it would stop the transmission of this, because the glitter would end up just on you and not end up everywhere on the environment. So those two simple steps, in my view, could significantly reduce the transmission of this disease and get us back to living our lives in a more normal way. Now, how long do we have to wear face masks? I don't know. I'm going to say a couple of months.
Yeah, I have a funny feeling it's going to be just like you're wearing a tie. A face mask is going to be kind of
designer face masks. I think it's the next big business.
No. And well, I'm glad you gave that explanation. We've all heard this, but one of the things that I found is that hearing it multiple times and hearing how people communicated in different ways. I love the glitter analogy, and that's fantastic. Okay, well, thanks for sharing that. Okay, so let's see. We've got a couple of questions, but let me get Kathleen has raised her hand. So Kathleen, can you hear me?
Looks like she's muted. I see a mute button on her mic.
Yeah, unmute. Okay, unmute. You might have to do it, Kathleen. Kathleen Weber. While we're waiting for Kathleen, Todd has a question. And Kathleen, if you jump on there, that would be awesome. You just got to unmute down at the lower left-hand side of your screen. Todd has a question. How is in-home care being affected, managed for falls patients being released from the hospital or rehab and in need of continuing assistance? And this is, I mean, certainly Dr. Dappen, feel free to answer this, but this is also one in the chat area. If anybody has some insight or assistance on that, by all means, jump in.
Well, certainly for a lot of the folks that, there are a lot of people that might fall, might need an x-ray, might need some labs done. It's hard for them to get to the hospital. They're either homebound or trapped at the house. And so there's a lot of services that can be brought to them to have those things done. And to my knowledge, radiation physics and the lab services are still coming in to do that. So I think they're I'm not sure how much they're wanting to do it if someone's a high suspicion of COVID, but under standard circumstances, they're willing to come in.
Great. Now, you brought up, again, I don't want to kind of go down a rabbit hole here, but can you give us an idea of how you charge and the rates you charge? Because I find it interesting, and just broad strokes, obviously.
Yeah, it's a good point. So we charge by 5-minute increments of time. So so we charge basically $40 per 5 minutes. And most of the stuff that you and I would need is 5 or 10 minutes. I have a urinary tract infection. I need some antibiotics. That's usually 5 or 10 minutes. So most of the standard stuff is, that grandma fell and we're worried about her pelvis and could you get somebody in to do an x-ray? That's probably 15 minutes. So that's $120. So it's as simple as the time we spend, and we send you a bill for 5-minute increments.
Yeah, and I can, again, attest to this model. For example, one of the times I had to call the doctor was I was riding my bike and a bee flew into my mouth and stung me, and my mouth swelled up. I was really nervous. I thought I was going to lose my breathing, and I stopped my bike. I called on the phone. By the time I got back home, I received a call from one of your staff, and we walked through some of the procedures. You had the screen up. You were doing research on bee stings and things of that nature, and were able to give me really educated feedback. And we went through this process. And when the bill arrived, because in essence we were only talking for 5 or 10 minutes.
Yeah.
it was very affordable, you know, and this is where I'm oftentimes referring people that don't have insurance to your practice, because all they have to do is pay for you to do a physical. Like you said, you don't treat strangers, so that now you know them and you have a file, and then they can have this access where normally, you know, somebody gets stung and they're nervous. Where are they going? They're going to an emergency room, and the emergency room doctor is not going to see you until you stop, until you really start stopping breathing, you know? And so this is
Well,
great.
and the last thing about that question, Steve, is the house calls, of course, are more timely because it takes us a while to drive there, um, and all those things. And a lot of the house calls are fairly complicated, so it's not uncommon to be there 30 minutes, and then the to and back. Um, so we charge kind of an arrival fee. It's $100 extra for us to come to the house, and then there's distance if you're farther and farther out. And then, you know, but usually we tell people, look, if it's usually we expect it'll be 30 minutes by the time we get there and spend time and figure out what it is and order the tests and get an x-rays or whatever. So it's not uncommon to have a bill that's $360 or something
Yeah,
by the time you pay my arrival fee. And
for home care and what have you. And if somebody
right,
has an insurance policy, they can file that on their own.
right.
But
It's
again,
secondary insurance will pay for it. Yeah.
if you've got a parent or a loved one who can't get out, I mean, the is, you know, a $300 bill to have a physician, you know, there
And the
talking to
first
them.
visit, we tend to just quote a price of $500 because it's going to be an
Yeah,
hour for us to be there.
yeah, exactly.
So
Um, a couple of questions coming in here. Question from the home care aspect. With this pandemic and wanting to keep people at home and safe instead of admitting them to get assistance on new meds or just additional care, are you or more doctors calling on home health care providers to assist those patients at home? Really good question. How do you work with traditional senior serving providers, from assisted living to home care to the whole plethora of other services that are out
well,
there?
so we don't reach out to them as much as just wait for them to reach out to us. So of course we've got some people who are living in assisted living or and different group homes, and so we wait for them to call for whatever it is they need. Um, and because of the current situation, we're not necessarily insisting that we have to see that patient for the first visit. We'll do our best to take care of them through the phones alone if we have to.
Okay.
Yeah.
But do you come into occasions with your clients who are living at home and potentially isolated and alone, where you're in a situation where you might suggest to somebody, you know, if you had somebody in here, you know, on a weekly, daily basis, or, you know, uh, bringing the family together and saying, you know, I've been, you know, working with you, Mrs. Smith, and I'm concerned about your safety here at home.
Yes.
And have you come into those over
All
the
the
years?
time. Yes, all the time. We are basically, saying it's, you probably need a caregiver. Uh, it, it, it basically, we're there just to try to make sure that we help that person get the services they need. So if they have a wound, we'll bring in visiting nurses. If they're having issues with not walking well and they're losing some of their strength and mobility, we'll recommend physical therapy. Some of the home physical therapy companies that can come in to do it. So we basically are trying to bring in any of the services they might need.
Mhm.
And to the point where even like when they are ready for hospice, we try to get people to age it in place if they, and a lot of people want to do that. So we take care of them. And then once there's a certain point where we'll say, hey, why not? It seems like hospice might be a cheaper and better alternative than using us at this point. Would you want to transition to hospice?
Yeah, and uh, I wanted to bring up something that you shared with us at the pro aging meeting on labs and how those are charged. But before, I just wanted to also talk about your practice and the geographic boundaries. Like Stacy asked, where are you located? How would you sort of define your service area? And with pro-aging and Sourcebook, we have a vast service area that stretches the whole mid-Atlantic. So I have no doubt that we have some people on here that are in Philadelphia, and we don't want to get their hopes up. But where are you located? And then are there other practitioners that are similar to you in other locations? I think you're part of a trade association of similar practitioners.
Well, so on the first question, we are in Vienna, Virginia, which is about 10 miles or 12 miles west of DC. And our service area is around, we go further than this if necessary, but we usually try to stay within 20 miles of the office. We prefer it to be shorter, obviously, because it takes so long to drive 20 miles in the metropolitan area. But so most of our patients are within like a 15-mile radius of the place of the central office. We also we do have quite a few people in Alexandria that are 20-something miles, and then we don't go into DC because I don't have a DC license anymore. I dropped that, and we used to go to Maryland, but we dropped that as well. We used to have Steve Simmons who worked with us, but he joined a different group. The thing about what other services are out there, unfortunately, I'm not familiar with anybody. So I consider myself part of what's called the direct primary care movement. This movement of what I've done, leave the insurance, do telemedicine, use a communication-centered model, try to make sure that I'm in relationship with the patient and that it's not about my relationship with the insurance companies. Some of these beliefs of what we think is important has become adopted and grown into a movement called direct primary care. But most of the direct primary care doctors that I know of don't do that many house calls.
Okay.
So.
Okay, great. Let's see. Susan asks, what would be, I mean, I realize that with COVID-19, you will see somebody who has not gone through the physical, but in a perfect world, what would be the initial visit cost?
So we usually charge $500 for the first visit. That's to get there. We expect it'll be an hour. So that's what we quote so that we can give people a fairly fixed number in their head. I know what I love about it is people kind of bristle a little bit. And I said, well, imagine what it's going to cost you to bring a plumber out to do an hour of work. It's going to be, it's like $500 is going to be the cost of the ambulance to take your dad to the hospital. It's like my getting out there to help you is a lot less expensive to the healthcare system. But one of the problems, of course, is the insurance model is people, once they're under that insurance, all the costs are deferred and not important to them.
Exactly. And I'm really glad that people are utilizing the chat feature on this webinar. I like how you guys are sharing other resources for home-based physicians. Again, Dr. Dappen knows there's other models. He's really very unique out there, and he's unique geographically too. And and that's part of what we're entering into is that this COVID-19 is making us a much tighter community. And the fact is that we need dozens of different models and practitioners that are willing to go into people's homes, which they weren't, okay? And that's the exciting thing about this horrible pandemic is that we're starting to reevaluate all these rules that we set up in terms of medical care and senior care. So, so by all means,
I might also add, Steve, that one other point that I often tell people when they, bristle a little bit about, hey, it's going to cost you $500 for me to get out there. But I would say, but the advantage is that a large percentage of the time, you just need to call us from here on forward, and we can handle it on a phone call, and that costs a fraction of what it would cost if I have to come out. So I don't mind coming out, but I know you don't want to pay that either. So let's just make it as efficient as we can and make sure that we're cost effective to you.
Yeah, no, that's great. Now let's kind of shift over into the technology and telemedicine world, because that is front and center for all of us. Tell us a little bit about the your kind of stance in this area. And again, I recognize the whole term telemedicine is now being overtaken by insurance, as opposed to practicality. And share your thoughts on that.
Very good. So a lot of people want telemedicine to meet, and you have to have very expensive video equipment. And so some of this debate is around the issue of what is truly telemedicine, because the face-to-face part is what is thought to be the telemedicine part. But the definition by the American Telemedicine Association is any method of helping a patient remotely. So it can be emails, it can be a telephone, or it can be a cell phone, it can be FaceTime, it can be any way you want it to. There's a lot of money to be made in trying to guarantee the security of the links. And so, the Telemedicine Association is filled with people who have interests to make sure that it is all HIPAA compliant and that you have to buy their expensive equipment. The part that I say is frustrating about that debate is that once I know a person, just their voice, I know who they are. It doesn't take me long to go, oh, you know me, I know you. And when the people talk about it not being personal by talking on a telephone, or that you're going to miss something, I just shake my head going, yeah, my family members that I don't want to hurt my relationship, so I don't let my wife call me on the phone because it might hurt my relationship, or because I can't see her on FaceTime and I'm just talking to her on a telephone. It's so impersonal. I don't want to do that with her, so I won't talk to her that way. So I find it totally ridiculous. It's like, come on, people, when they need to communicate whatever's the best way. If I need to do it by FaceTime, let's do it. Our medical record system has a embedded telemedicine system, so I can send you a link just like Zoom that goes through a secure sprocket. So if we need to do something through a secure system, we can do it that way. But a lot of times, just pick up a phone and call me. I can figure out, just hearing your voice and knowing who you are, we'll figure it out. Let's figure it out.
Yeah, and I don't know if it was you or another presentation that I went to that really helped me kind of understand the scope of what we're now kind of referring to as telemedicine, but I'd rather refer to it as technology that can help us deliver better care.
Right.
Whether it would be you or the speaker was sort of referring to, something like this watch right here that I've got. It's a Apple Watch that records my, various aspects of my health, my pulse, my heartbeat. It could record my blood pressure over a period of time. And what either you or somebody else was saying is that, your traditional physician visit, your traditional physical is taken, it's reviewing data in your office at one point in time. It's what is your heart rate right now when I stick the stethoscope on your chest, as opposed to the exciting thing is that we can use these devices to record our health information over a broad period of time, and a doctor can actually take some time and study that before you even arrive at the office and ask relevant questions over a period of time, as opposed to that 5-minute period that you're talking to them when you're probably nervous to begin with, or not feeling well, or what have you. Have you sort of started to utilize those types of things? I think it was either you or another doctor also said, he goes, I used to work in the best sleep study center in the nation. And we would make people sleep in this bed that they've never slept in before. And he goes, now with sensors, I can study people's sleep in their own bed. Right. And he goes, 9 out of 10 times, they're allergic to something in their room, which is why they're not able to sleep, Any thoughts on that?
Well, yeah. So I mean, I think that a lot of this equipment is, everybody's building a lot of these interesting devices for watching your blood pressure and watching your blood sugars and watching your pulse rates and checking to see if you go into AFib or not. Lots of data can get produced. The hard part is that I find it interesting because for me to be vigilant of it and paying attention to it and watching it and thinking about it and trying to put it into context means it's going to take me time. And if I don't get, like anything that's happened in the healthcare system, people didn't want to pay me to do telemedicine. So no money, no mission. It can't happen unless there's a real reason to do it. So doctors not going to waste their time watching all that data unless they need the data to help you manage a certain condition. So a lot of these devices just generate tons of data, but for the doctor to say, I'm going to take responsibility to look over that data, where you spend minutes every day looking over a person's data and never get reimbursed for it, means that, and then they're liable for it if they make a mistake, so they really have to watch it. Then it's just like, it's danger, it's toxic territory to running a business if you want to know the reality of it. I mean, that's the reality.
Absolutely.
So,
well, this is great. I want to let everyone know that we're going to try to wind things down here. So if you've got questions, comments, now is the time to jump in, because I know everybody's time. We got to get back to our next webinar that you've got after this one.
COVID, since COVID-19 is the common theme today, the common thing happening, is there anything, a need to know question that I might be able to, I don't know if I can answer it, but I could try.
Yeah, no. And part of these webinars, this is for you, Alan, it's the first one you've been on. A lot of times these webinars are really, they're like support groups. We're all in this boat together. We're all reinventing senior living together. And whatchamacall. So any sort of challenges that people are going through or any questions are very important. Let's see, Dr. Dappen, there's a comment there. Can you provide contact information for referrals? I will make sure to send out all the information in my follow-up email to everybody. But Dr. Dappen, what is the best email for people to reach your
probably
office?
My email address would be the easiest. Of course, you can always you can call in and speak to our nurse manager, Gail.
Okay, what's
our
that
office
number?
is 703-938-4600. If you want to talk to the doctor group, there's
460. You said 703. Okay, and then
there's
an
extension
email.
1 that takes you to me or to whoever's one of our nurse practitioners on call.
And then how about an email for you?
And then for me, Alan, ALAN .Dappen, DAPPEN, 2 double P, .MD at doctalker.com.
Okay, MD at, and it's DOC.
Talk to your doctor, TALKER, like a talk.
Okay, I put that in the comments.
Perfect.
Whoops.
That's
I
it.
need to put that in the comments for everybody.
Is there a way that we can get a copy of all the chat comments?
Yeah, I'm going to cut and paste those, and I'll
you.
send those out as well, because I found that's very good for networking.
Super useful.
As well.
Thank you.
Yeah. Let's see. Okay, so this is fantastic. We're going to kind of wind things down, but I want everybody to know this is the first of weekly spotlights where we get to chat with providers. So next week we have Dr. DeYoung. He's with Capital Caring Health, which is a new practice. They do home visits too, but it's different from Dr. Dappen. And then I want to get the Inova platform, Allegiance, find MedStar. Like, we need to learn about all of these and understand. What I want you guys to do is I want everybody to have this, know that Dr. Dappen's out there for a resource for your client if they have specific needs. But more importantly, I think in this, when we get out of the woods with this COVID-19, which we're never going to return to the same woods again, okay? We need to sort of use entrepreneurs like Dr. Dappen as inspiration on how can I reinvent my business? What are the things that work? And not be afraid to take the bold step. I think you used to refer to yourself as your wife's art project or something like that. You know,
Good memory, Steve.
but because I mean, I can't imagine, you know, what you potentially sacrificed by taking the risk to start this practice. It's like, listen, we all want our kids to go to school and become doctors and lawyers because we know they're going to have steady income for the rest of their life. So Dr. Dappen is a physician that took that risk to kind of do something that, you know, was a little speed bump to, you know, the traditional path to a physician. But I think ultimately the work of art you created, I find it to be very interesting and
Thank you,
very
Steve.
useful from a consumer
Appreciate
point
that.
of view. Yeah. So, well, guys, this is great. I don't see any sort of pressing questions. So
did Kathleen get her question answered or asked? Kathleen Weber?
You know, I never got her on. We never got her. Do you see her?
I see her on my screen. I can see that she's a dark screen with her name and a muted microphone thing.
Yeah, no, we never got Kathleen. Here, let me see. Kathleen, can you unmute or talk? Kathleen, ooh, I think we might have you. Can you hear us? Oh, well. I love Kathleen too. She's with Holy Cross Health, and
cool.
She's just an awesome
Steve,
woman.
The chat function stuff, are you going to send that to us as an email? How are we going to get that?
Yeah, I cut and paste it, and I'll send all this to everybody.
That's wonderful. Thank you so much.
It says, I read somewhere that you speak fluent Spanish. Is that true?
It is true. Well, let's just say it's pretty good Spanish. Fluency is one of those words that there's lots of layers. But I grew up in Mexico as a small child, and so I've lived 8 years of my life in Mexico. So, So Andy Casito, who's just jumping on there, I was thinking of her as I said this. She and I chat Spanish, and then I'm always like, "Yeah, Andy, you're gonna blow my Spanish off the ground."
Yeah,
here.
Andy, I'm trying to. There. Okay, Andy.
Hi, how are you?
Good.
Hi, Doctor. Hi, Steve. How are you?
Andrea. Hi, Andy.
Fine.
Andy, tell everybody who you are. Tell everybody who you are.
Okay, I'm Andy Cosito. I'm the owner from Tyson's Wood Assisted Living. So I have the two communities very close by. So while we are working hard to protect our resident and of course our caregiver, which is very important, mostly are working here from the house. They are, if they need to go home, I drive them home, and I try, to keep everything as better close together. So, and with Dr. Dappen, we are always on the phone. We have residents here. And so that's what we are doing right now, trying to stick together.
And Andy, you're from Argentina, correct?
Correct, I'm from Argentina.
So can you attest to Dr. Dappen's Spanish?
Sí, el doctor siempre hablamos juntos, ¿no?
Sí, cierto.
All right. That's cool. That's really cool.
So
awesome.
Somebody needs to speak German, then I offer German too.
Great. All right. Well, guys, this is great. We're wrapping it up. I'll follow up with everybody, and thanks, Dr. Dappen. Thanks for everybody who came on the call.
Thanks for doing all this. I appreciate it.
Okay, thank you for everything.
Ciao.
Okay, you bet. Thank you.
Thanks.
Por ahí medio segundo la